I think that our legacy media has not done a good job in providing balanced coverage about the vaccines. To just give you a personal example, our paper was published 3 weeks ago, but I've received no interview requests like this from American broadcasters or even major American newspapers. So, and I did try and reach out to them because I think it's an issue of major importance. But I think there's a lot of nervousness about how to have a discussion about side effects, about harms. There's not a degree of sophistication about how to do this properly, it seems, and as a result, we don't get any information about it from we're not getting the information that we need to make better choices and to have a more informed understanding of risk and benefit. It's very unfortunate that from the beginning, a what was presented to us by public health officials was a picture of great certainty about what we know about these products. But the reality was there were extremely important unknowns at the time of the mass deployment and authorization back at the end of 2020. And I think that as a result of projecting certainty rather than uncertainty and bringing the public along in this moment of uncertainty, we entered a situation where essentially the stakes became too high to later present that uncertainty to people, because how could you be uncertain later about something you were certain about? Uncertainty should reduce over time, not increase over time. And I think that that's what set us off on the wrong foot. And from the beginning, we should have been, public health officials should have been a lot more forthright about the gaps in our knowledge. The eight mice, you know, it refers to the evidence base that was presented in June of 2020 to our U.S. Advisory Committee. Now, there may very well be more mice at this point in this recent September authorization that happened of the Omicron booster. Um, it still does remain, though, that the evidence base for this latest Omicron booster is based on mouse studies. That hasn't changed. There are no results from human clinical trials, which is what we need, but those results don't exist at this point. I think there are probably more mice at this point. It is a fact, though, that data on 8 mice were presented in June. Now that was a slightly different set of data, but the data are included. They're part of what FDA is reviewing when it's making its decision when it made its decision this month. So the bottom line, I think what's important is not to be counting the mice. It's to be realizing that we're only talking about mouse studies, and what we need to be talking about are human clinical trials. That's the kind of robust data that gives us more certainty about the effects of these products in humans. Right? That's what we need, and that's not what we received prior to the authorization of the latest boosters. Right? In fact, when the FDA this month released the information on the booster, when the FDA earlier this month authorized the boosters, they said it was on the basis of those mouse studies as well as what we know from the clinical trials. And the clinical trials are exactly what we analyzed and reported on in the study that we published a few weeks ago in Vaccine. So the clinical trials, the human clinical trials, which goes us back to 2020, are actually very relevant and are cited as part of the basis for making the regulatory decisions today. We're an international group. of physicians, academic researchers, and what we did is a reanalysis of the original clinical trials that supported the Pfizer and Moderna emergency use authorizations back in December 2020. So we presented these results to the EMA and the FDA in March this year. We met with them over Zoom. We had Zoom meetings. Both of these agencies took us seriously, and I think our analysis improved as a result of those meetings. We importantly encouraged them to replicate our analysis. And then we went on, as you know, to publish those results in the peer-reviewed journal Vaccine. So what we found is that both the Pfizer and the Moderna trials are both showing a clear signal of increased risk of serious adverse events among the vaccinated. Now, serious adverse events are events that the companies themselves have classified as being of the most concerning quality. Namely, it's usually something that lands you in the hospital, and that's why it's classified as a serious adverse event. And the trial data are indicating that we're seeing about an elevated risk of these serious adverse events of around 1 in 800 people vaccinated. So one additional serious adverse event for every 800 people vaccinated. Now that is much, much more common than what you see for other vaccines, where the reported rates are in the range of 1 or 2 per million vaccinees. In these trials, we're seeing 1 in every 800. All right. So, and this is a rate that in past years has had vaccines taken off the market. Just to put that in some perspective, like in 1976, we had Guillain-Barré syndrome after influenza vaccines that were then, withdrawn. So, and the other thing in terms of background to understand is that we're talking about randomized trials here, right? There's a lot of studies out there, but we're talking about randomized trials, which are widely considered the highest quality evidence. And we're talking about the trials that were submitted by Pfizer and Moderna that supported the regulator's authorization. So the results are really raising concerns, particularly about the safety of the mRNA vaccines in low-risk groups. And that's why it's really important that we have an independent replication of these data using the individual participant data from the trials. This data comes from their studies. We are not, if they said it's a serious adverse event, we're treating it as a serious adverse event. We're not looking at the data and saying, oh, we think this is serious, but you didn't call it serious. No, these are from their tables. So take the Pfizer trial, for example. Yeah, in the Pfizer trial, there's around 5 serious adverse events per 1,000 people in the placebo arm. But in the vaccine arm, it's close to around 7 serious adverse events. And that's why for the Pfizer, for 7 serious adverse events per 1,000. And that's why you get in the Pfizer trial this 36% increased risk. But if you're looking at how often is this occurring, it's around, for the two vaccines together, it's around 1 in 800. Right? 16% increased risk does not mean that out of 100 people, 16 will have a serious adverse event. You have a baseline risk that you see in the placebo group, right? Serious events occur that are unrelated to the vaccine. The question is there an increased risk that's associated with the vaccine? And that's where the increased risk is that 16% higher. I think it's helpful to tell more of a natural frequency type, statistic, which is 1 in 800. If you want one statistic, 1 in 800, because it tells you about how often it's occurring. So it's one additional serious adverse event per 800 vaccines. Yeah. And you compare that to what you see for other vaccines and what you hear, which is something that's exceedingly uncommon, 1 in 2 per million. That's a huge difference from what our expectations have been. So our paper, as you know, is focused on analyzing these serious adverse events, which are the most concerning types of adverse events, the ones that are bad enough to land you in the hospital. Those are serious adverse events. But to put it in perspective, we did compare this against something that we thought would be roughly equivalent, which would be reductions in COVID hospitalization. So that would be the other side of this balance. And what we see in the trial data are 14 reductions in COVID hospitalizations across the two trials. It's not a large number, but they're all right. 14 hospitalizations all in the placebo group. So there was this reduction in the risk of COVID hospitalizations in these two mRNA vaccine trials. The size of the reduction, if you want numbers, the size of the reduction is on the order of about 6 per 10,000 people in Moderna and 2 per 10,000 in Pfizer. Now, if you compare that against the serious adverse events, you see that the serious adverse event increases are larger. So they're on the order of 15 per 10,000 for the Moderna and 10 per 10,000 in the Pfizer. So if you're looking at this to weigh this against each other, what you're seeing is that there's these larger increases in serious adverse events than we see compared to the COVID hospitalization reductions. So as far as infection, the trials were never designed to study infection. That's the most important point. And that limitation was noted in black and white. It's written up in the FDA's reports from December 2020. Very clearly, it was a complete unknown because the trials were not designed to answer that question. But that major unknown, that caveat that we don't have the data to say anything about the prevention of infection at the time of this mass rollout, that seems to have gotten completely ignored by governments that were pursuing a herd immunity strategy. The herd immunity strategy makes a fundamental assumption that you're stopping infection and transmission. That's what the herd immunity strategy is all about. Yet we didn't have the evidence base to say whether or not there was that performance of can this vaccine stop transmission. And in fact, there were reasons to think that it may not stop transmission. One of the big ones is that this was an intramuscular vaccine. And this doesn't produce mucosal immunity. Infections in the terms of COVID, in terms of influenza and other acute respiratory infections start in the mucosal membranes, right? They start in a place where these vaccines are not particularly good historically at producing immunity, antibodies in these areas. So it's not at all a surprise that we learned the hard way, right, in 2021, that there wasn't this dramatic effect against the prevention of infection. That to me is actually quite unsurprising. But it's more surprising that we could pursue a herd immunity strategy, making an assumption that we didn't have data to actually know that was a correct assumption. I think that over time there's an increasingly small population, group of people for which one can theorize that the benefits will be outweighing the risk, right? That's going to be the highest risk population. But what we're seeing today with Omicron is that the COVID epidemics today, right? What we're seeing today looks very different from what we saw in the past, pre-Omicron. And so the risk profile, right? How much of a risk does COVID present to people has to be understood when you're making a risk benefit or a harm benefit type judgment. And for those at low risk, the data we have clearly indicates that we need to reevaluate what we're doing in this area. So I'm very interested, right, and watching very carefully and with interest what's going on in places like Denmark, where there's now been a recommendation for that routinely nobody under 50 needs to get vaccinated. Only special cases with medical need. So that's what's going on there, is a realization of the risk posed by COVID these days. It's not what it was in the past because of various things, right? And the harms, though, on the other side that we're talking about in these trials, there's no reason to think that these risks are going away. And if these are related to vaccination, they're not. one wouldn't presume that they somehow go away over time, right? Yes, we have reformulations, and we should be getting clinical trials to know that. But unless you have the absence of information, you're going to, as FDA did, look at what do we know from the trials. And that's why these results are so concerning. And so what really needs to happen, I think, next is we need to figure out which types of people are at risk for these serious adverse events, right? And if it is the low risk population, that's very bad news, because low risk people have much less to potentially gain from COVID vaccines. So the side effect profile in such people has to be extremely low. Now, how do we get that information? Well, how do we get the information? One of the next steps is that we need access to the raw data, right? I mean, this is one of the most amazing aspects of this, is that EMA, and right, doesn't EMA is your regulator, covering the EU. They don't have the raw patient level data. They do not have it. The FDA has it. FDA has, right? The companies have it. We've asked the companies to release the data. They haven't released the data. The data are not publicly available at this patient level data. But if you want to understand what is the risk benefit at various risk levels, particularly thinking about age, for example, you need to have these more granular data. So that's what, I think any responsible public health body should be doing immediately. I don't know. I don't like to guess about people's motivations, but it is very concerning if to think that we have a product that's been rolled out globally to hundreds of millions, billions of people, yet the raw data for these products is not accessible. I mean, on that basis, why should we be considering these products to be based on science? Science is about the sharing of data. Science depends on that. We're in an era of open science, not secret science. We should be demanding that. And I think, how can one recommend responsibly that these products are based in science if the data are not available? We're approaching now 2 years that these products have been rolled out, and still the data are not accessible for the original trials. I don't know the Paul Ehrlich Institute figure. I don't know how it's derived. What I can tell you is that what we see in the randomized trials that supported the authorization, and these are the only randomized trials we have to go on, right? What we see is one additional serious adverse event per 800 vaccinees. So as you said, that's 12 times more common than the Paul Ehrlich Institute figure. So, and then if you disaggregate the data in the Pfizer trial, there's an additional 18 serious adverse events per 10,000 vaccinees. Right? So I don't know where they're getting their data. I would want to know if it's from the randomized trials or something else, because what we're going on is what we see based on the randomized trials, where we have a control group, we have a baseline rate, and we see what happens when you vaccinate people. How does the baseline change? Does it drop the baseline? Does it increase the baseline? That's where we see the increased risk. So it really seems of limited use, this number, and there's too many caveats that have to be presented with it, because we're talking about self-reports most likely in this case. Who's making the judgment about whether it's serious or not? Is it something that results in hospitalization? I would imagine that they're also saying that there's no reason to think there's a causal relationship. I imagine they're also saying this if it's just post-marketing reports, because they're just reports received. They haven't been established as causally related. What we're talking about here, what I'm talking about in our study, are the randomized trials. I mean, this is comparing, the gold standard, if you will, that it's usually considered the gold standard of medical evidence, with the standard that regulators are typically very quick to say we don't know that this means anything. I think absolutely it should. As I said, I'm encouraged by what's going on in countries like Denmark, because I think there seems to be a greater realization there that with Omicron and COVID today, we're not looking at the severe epidemic that we looked at in the past. We're looking at something very different. So you have to be judging the potential benefit against the risks, particularly serious risks in light of this information. We're looking at populations in which there's a lot more people today that have already had COVID, that have been infected with this virus. I mean, much has changed. And as I said, for children, the risk benefit was unclear from the very beginning about the vaccines. Very unclear from the very beginning. A lot of this was based on extrapolation, not a demonstration from the trial data. No, I don't believe compulsory vaccination is justifiable, especially given what we've discussed about the lack of compelling data that they are reducing the transmission and stopping epidemics, leading to herd immunity. And now that we have findings from these trials, concerns about serious adverse events being higher, much higher than were conveyed, I think that the compulsory vaccination is even less justifiable. I mean, any responsible public health body with the data, the report that we presented, based on the trials that they should be having access to. But as I said, they don't have the full access, just as we don't have the full access. But they should be doing a couple things. They should immediately be warning people about this safety signal that has been reported, that we found, and they should immediately be replicating the analysis. They shouldn't trust us simply because we published it. They should be replicating this analysis. And to do that, and to extend the analysis, to do an even better analysis, they should be demanding that the companies provide them with all the data. EMA does not have all the patient-level data. But if you want to figure out the harm benefit, particularly in subgroups, you talked about younger people, then we need to have those data for the whole trial. We'd have to have the patient-level data in order to understand what the serious event look like in the younger groups. Yes, they should have done this from the start. When you're entrusted for protecting the public's health, and you as a regulator, you need to be in receipt of all the data. Not summaries of the data, but all the data. The most granular, detailed data should be all in your possession, and you should be going over that with as much scrutiny as you possibly can. That's a responsibility, I think, that the regulator has. As far as what we can do, we're limited. As I told you, we have written the CEOs of Pfizer and Moderna in a public open letter asking for the data in order to refine our estimates, in order to have more information about the subgroups and how these harms, what is going on at a subgroup level. We asked for the data. We have not received a reply. It's going to take not simply us asking for data, it's probably going to take the media to highlight that regulators are not in possession of the data, and that independent groups like our group, which wants to analyze the patient level data, has no access to it. And so there is no ability right now for independent researchers to say, I've looked at all the data myself, and I can tell you, here are my conclusions, because independent investigators can't get access to the data. We're getting close to 2 years past authorization, and we still don't have access to the data. These data should have been accessible back in 2020. What it tells us is that the data are indicating this increased risk at a level that is much higher than has previously been realized. Right? 1 in 800 is a much higher rate than what we've been thinking. 1 in a million, 2 in a million, right? So that's what the data are indicating. What it doesn't tell us, as I was saying, it doesn't tell us what does it look like in children. Where were the reductions in COVID hospitalizations? Presumably, one could guess that they're in more higher risk people. And so you're not seeing such a benefit in healthier populations. But we can't say that for sure. We would need the access to the raw data to know that. So there are still unknowns here. There's unknowns about what exactly does the risk harm benefit look like today in the context of Omicron, in the context of populations that have much larger baseline immunity, in the context of a place where there's mandates. I mean, there's a lot. I guess there's a lot of things that are still unknown. But I think the most important unknowns are what to refine these estimates, right? To have other people replicate these analyses in order to have more certainty about what we reported.